Well, maybe I'll start with the IVUS. IVUS is intravascular ultrasound.
Okay.
It's basically, it's like a catheter we put inside of a vein or artery, and it gives us pictures from the inside. The nice thing about IVUS is that it gives us real-time visualization of valves, for instance, moving structures, very intimate details of the vessels and the stenoses. We can also use flow measurements and pressure measurements at the same time or in conjunction with these IVUS pictures and get really detailed in vivo or in the body data.
Is this being used at all right now in the
I think
CCSVI?
intermittently there are sites that are using it. I think as time goes on, more and more it will probably be used in more significant numbers. I think it'll serve as a very useful tool for validating whether or not the MRI data, the flow data, is valid, which will be great because then we can say, you know, we know for a fact that when we do this MRI, it's giving us a really good picture of what's actually going on inside the body before we ever have to go in. I think the IVUS may also prove to be a very useful tool in evaluating restenosis. You know, restenosis is the idea that astenosis or a narrowing comes back over time. At some point in time, you will restenose. You know, none of these angioplasties are forever. The question is, when will you restenose? As it is with any other part of the body, you know, the arterial system, the heart, you know, there's tens, if not hundreds of millions of dollars that go into research how to slow down or prevent restenosis.
There's also a number of other effects that are happening in the tissue, such as inflammation, that are going to make the body more prone to restenose, I would imagine. Eh?
I would agree.
Something.
So perhaps in order to study this, we need to sometimes look outside of our own area of interest. And there is work by other investigators that demonstrates that if you disrupt the vasculature, you will have an effect, for example, on the vessel wall, and that's perhaps most clearly demonstrated in atherosclerosis, where I'm sure you also have to put in stents in those cases to deal with very tight stenosis of the carotid artery.
Right.
So that theory has been developing for 20 years, and it's known that the flow rates and the shear stresses against the wall all affect the response of the wall. In the last 10 years, this has also been demonstrated to some degree on some of the venous systems, and there's some very interesting animal work by John Bergen in this direction, and this concept perhaps of marrying our vascular interests with immunological research to do what I like to refer to as sort of a future direction of vascular immunology will be important. But I'd kind of like to turn the tide around a little bit toward you here, and do that first by kind of linking everything we've talked about. I think it's very critical that we have a means, and that the neurologists be involved in this as well, of monitoring the patient's status, whether it's cognitive status or motor status,
Right.
by using methods such as EDSS scores or MSIS-29 scores or other neuropsychological means and motor means to determine, you know, the state that you're in at the moment, so we can follow people over time and see are they getting better or not. That's got to be part of the next level of research as well. And you know, with all of these thousands of people who've been done, that data isn't available, which is a shame. Now there are some groups like David Hubbard, who's got a national protocol where he wants people to begin contributing to such a database. There's already a European database. I know that in Canada they're interested in creating such a database as well. I think it behooves us to get as many interventional sites involved as this is possible. Maybe they can't all be involved because that's going to require a lot of work. But Joseph, I think this was something you had expressed an interest in from your perspective to get involved in that level. And the reason I raise that relative to you is that if you've been seeing a physical therapist for years, and they have years of records to demonstrate what your status was, your ability to squeeze a ball, your ability to walk, all of these quantitative things that they actually do keep records of. And then you've had this treatment, and you go back to your physical therapist, and now you're able to walk at a better gait, you have to put more pressure on this, which can be measured. All of these things would become actually important scientific information, because now it would demonstrate whether or not you really had improved in a variety of ways that aren't so subjective to saying, I feel better. And I think that's a really important part of what we need to be looking at internationally at the moment. And Joseph, I hope that's something that you're interested in too.
Yeah, absolutely. I think we would love to show some long-term data that shows that patients, we can say, these are your symptoms beforehand, and try and quantify that somehow, and these are your symptoms immediately after the treatment, 6 months later, a year later, and really start to perhaps try and correlate some of those symptoms with what we're doing as well. And I think along those lines, I think ours and other practices, we're very interested in formulating questionnaires for our patients that really try and extract some of that data to help us correlate it with the treatment and track it over time as a response. And also, quite frankly, correlate some of that really useful clinical data with the imaging data. Because in an ideal world, we'd be able to look at an image and say, yeah, you have these 15, 20 signs that really tell us that if we do this thing has a very high likelihood of helping you in this manner. But until we get this clinical data married with the imaging data, married with the treatment data, it's not going to happen.
And if we begin to do this now, recognizing that thousands of patients are being done, then there's the potential to accomplish, perhaps, I'm not exaggerating, I believe, in 1 year what it currently takes about 10 years to do with federal funding. Because in this way, it's very expensive to do this research at a hospital and to get federal funding to do it. If people are contributing this from freestanding sites and from other hospitals, this reduces the cost dramatically to save that data, to evaluate that data, and since it's being done anyways, this becomes data where, in a sense, everyone is contributing to the national benefit of studying this disease. And I think this is a direction we have to go. This is really the 21st century direction of improving medical research and making things more cost effective and making things more available much faster for the patients than they're being done today.
Excellent.